Good evening, everyone. Hi, this is Dr. Anil Mirchandani. I welcome you all for this session on must-know topics in obstetrics. After amazing gynecological session, I hope you people are ready for obstetrics now, and I hope you people are doing well. Already you are a clinical classical case of post-term pregnancy, my dear friends. You were supposed to deliver in January, but still you are intrauterine pregnancy. Thankfully, the placenta is doing well and you are getting good blood supply. And yes, my dear friends, continuous revision and continuous listening to the topics is most important thing. And yes, in this session we will be talking about most important things in obstetrics which you should know. The difference between gynec and obs would be, in gynec there would be symptomatology and then there would be diagnosis based on the algorithms which madam had covered. In obstetrics, the questions would have the chapter's name in it. If there is a twin gestation, there would be twin gestation. If there is hypertension, hypertensive disorders in pregnancy. Diabetes, there would be question on diabetes, and yes, there would be something related to blood sugar evaluation. So my dear friends, without wasting time, let us all start with must know topics. And I miss you all, and I hope to see you all as resident doctors soon. Chalo, let's start with our must know topics in obstetrics. Let us start with things which you already know. Let us start with the topic called as multifetal gestation. And this in this era of clinical vignette, where you are supposed to know the clinical things, you are supposed to know the photographs and the managements, the management protocols based on what is asked in question. Here is one photograph which is commonly asked in exam. This is the photograph of dichorionic, diamniotic twin gestation. DCDA twin gestation. As you can see, there are three layers, A, C, C, A. Three layers would be there. So CC would be combined, and this is chorionic layer. And this might be given in question as this: the ultrasonography finding of a lambda sign. So it might be a question like 28-year-old gravida 2 para 1 living 1 with ultrasonography showing this picture. This is dichorionic diamniotic gestation. Yeah, DCDA. And yes, there would be lambda sign seen. Lambda sign is seen in dichorionic diamniotic, and you all know that dizygotics are always DCDA. Dizygotics, if they are made from two zygotes, they are always DCDA. Yeah. Monozygotics are of four types. You know that: MCDA, DCDA, MCMA, and conjoints. Monozygotics can also be DCDA. So can this picture be of monozygotic twinning? Yes, sir. Monozygotic twins can also have this picture. Dizygotics will always have this picture. This picture is lambda sign, also called as twin peak sign. We know that, we have done this twin peak sign. It is best seen between 10 to 14 weeks of gestation. Yeah, guys and girls. So if you want to write down, then you should remember lambda sign, DCDA. You have already written all these things in our notes. This is must know essential topics with all these things already given in your notes. I want you people to write down if you can, but if you're not able to write down, no problem. You're already written in your notes. Be very attentive. That's the most important thing. Yeah, dizygotics, monozygotics. Now, what you must know about dizygotics and monozygotics is that if it is dichorionic twin gestation, which is not complicated by hypertension, not complicated by IUGR, not complicated by diabetes, then the recommended time of delivery is 38 weeks. So 38 weeks for DCDA. Yeah. So when you get a question, you know that the termination has to be done. That means delivery has to be done by 38 weeks. Am I clear about this? If it is monochorionic diamniotic, how will you know that it is monochorionic diamniotic? There would be two placentae. There would be one placenta. Yeah. and there would be 2 amniotic sacs. So sonography would show T sign, yeah, thin septum, T sign, thin septum. T sign, thin septum would mean only 2 layers are present in between 2 babies. Baby is here, and there is a 2-layer thin septum present between 2 babies, and the 2 layers are made by amnion. Yeah, that is why it is called monochorionic diamniotic, MCDA. Are these monozygotic twins? Yes, of course. Monozygotics are of different types. When are you supposed to deliver these babies? Remember that if there is monochorionic diamniotic twinning, then termination has to be done between 34 to 37 weeks 6 days. This is the time when you should terminate the pregnancy. So my dear friends, right now I have shown you a picture of DCDA, and I have told you 38 week is the time of termination of pregnancy for DCDA. Then if in this picture, imagine there is no chorion in this. Imagine there is no chorion in this. There are only amnion layers in this. I will not label it as dichorionic then. It would be called as monochorionic diamniotic. If this chorion layer is not there, only AA are there, then it is monochorionic diamniotic. Yeah, it would be seen as which sign? T sign. Monochorionic diamniotic, T sign, thin septum, 2 layers. Yeah, are you writing the key points? If you are writing, then remember 2 layers would be amnion. Timing of termination of pregnancy 34 to 37 weeks 6 days. Am I clear? And if patient has monoamniotic twin gestation, monoamniotic would have no septum in between 2 babies. The babies would be floating in the same amniotic sac. Monochorionic, monoamniotic, no septum in between 2 babies. Yeah, this condition is very rare. This is called as monochorionic, monoamniotic, and recommended time of termination is 32 to 34 weeks. You remember 34 is the best answer, but 32 to 34 is the range. This is the time of termination. Question: how do we terminate, sir? Whether we should do vaginal delivery or we should do cesarean section. Remember, monochorionic, monoamniotic should preferably go for cesarean section. Why? Because there is a risk of cord entanglement. There is a risk of cord prolapse because the babies are there in the same amniotic sac. Am I clear, guys and girls? So I am telling you again, monochorionic, monoamniotic, your answer would be cesarean section at 30 to 34 weeks. Yeah, cesarean section. Others can have vaginal delivery. DCDA, MCDA can have vaginal deliveries. Yeah. If first baby is cephalic, then you should prefer vaginal delivery. If first baby is non-cephalic, it's not compulsory, but it is better you do cesarean section. Yeah, it is relative indication, but it is an indication for cesarean section. Yeah, can they have vaginal delivery? Yes, of course, but it's better that cesarean section is done for the same. I will make one question. 28-year-old patient, gravida 2, para 1, living 1, 34 weeks of gestation, twin gestation. USG shows no septum in between 2 babies. Yeah, if this is asked in exam, yeah, if it is written first baby cephalic, second baby breech, first baby breech, second baby cephalic, doesn't matter. What is written is no septum in USG. That means it is monochorionic, monoamniotic, and 34 is a deadline. Your answer should be cesarean section. Am I clear about this? So monochorionic, monoamniotic, cesarean section by the latest figure 34 weeks. Okay, that is what you should know about the twin gestation question. I'll make one more question. 28-year-old, gravida 2, para 1, living 1, twin gestation, and she is, let's say, 34 weeks of gestation, yeah, USG shows lambda sign, thick septum. These things are written. First baby is cephalic, second baby is breech. What are you supposed to do? The answer is wait and watch. For spontaneous onset of labor, we have to wait and watch. What if you're waiting and watching in this patient 34 weeks, DCDA, yeah, dichorionic diamniotic, 34 weeks, you're waiting and watching. Why you're waiting and watching? Because first baby is cephalic, you can attempt vaginal delivery. What is the deadline by which you can, till which you can wait and watch? The deadline for DCDA is 38 weeks. Then what are you supposed to do? Your answer would be induction of labor. Yeah, 38 weeks over induction of labor for DCDA. These are the deadlines. If it is monochorionic diamniotic, 34 to 37 plus 6 weeks. Let me tell you an Indian scenario, we terminate by 37 weeks. We reach 37 in MCDA and terminate. But then that's a range, 34 to 37 plus 6. Yeah. Am I clear about this, guys and girls? So you should know about these clinical vignettes and yes, about twin gestation. One more interesting question about twin gestation is about this picture. If you see such a picture where colored veins and arteries are there in the placenta, yeah, and you can see some connections between the vessels of the two babies. Obviously, there are two cords, there are two babies. There are connections between the two babies. This is a clear-cut picture of twin-to-twin transfusion syndrome. Yeah, twin-to-twin transfusion syndrome picture is this one. Guys, can it be seen in a dichorionic placenta? No, never. Can it be seen in dizygotic condition? Zygotic twinning? No. It will be seen in monozygotic. Of course, yes. But not in all monozygotics. It will be seen in monochorionics only. Yeah, monochorionics. The baby is sharing same placenta will be possibly having anastomosis between the vessels of the two babies. Yeah, it is due to arteriovenal malformations. Yeah, arteriovenal malformations between the two babies. Yeah, placenta sharing AV malformations, also called a deep anastomosis. That is why one baby is donor baby, other baby is recipient baby, and you know this, that investigation of choice would be USG Doppler. So if you ever see that there is twin gestation and one baby is large, another baby is small, you are supposed to do Doppler in order to see abnormal connections in between the two babies. Yeah, guys, USG Doppler is necessary. And if Doppler is showing you that blood is flowing from one baby to another, it's a clear-cut case of twin-to-twin transfusion syndrome. Donor baby and recipient baby. Yeah, which baby has high mortality? Recipient baby has high mortality. Yeah, guys and girls, remember this thing, the treatment of choice for twin-to-twin transfusion syndrome is laser ablation of AV malformation. What did I say? When there is monochorionic twinning, monochorionic diamniotic twinning, it's a possibility that twin-to-twin transfusion syndrome is there. What is the cutoff for monochorionic diamniotic? I told you 34 to 37 plus 6. In twin-to-twin transfusion syndrome, see to it that you terminate by 34 weeks. There is twin-to-twin transfusion syndrome. You are doing laser ablation of AV malformation and then terminate at 34 weeks. Am I clear about this? Guys and girls, so take home message that twin-to-twin transfusion syndrome is due to AV malformation in monochorionic twinning. Yeah. USG Doppler will be investigation of choice and treatment of choice would be laser ablation of AV malformation. And yes, you have to terminate by 34 weeks. Lung maturity is achieved, terminate. You don't want this pregnancy to continue beyond 34. Am I clear? Yeah. What's the deadline for monochorionic monoamniotic? I told you 32 to 34. What about monochorionic diamniotic? 34 to 37 plus 6. What's the deadline for dichorionic diamniotic? 38 weeks. Yeah? I hope you understood this. This is about twin gestation, what you should know. Regarding breech presentation, that's our next topic. Guys, here you should know these maneuvers which we have done in our your videos and lectures, face-to-face lectures, yes, and yes, recording lectures. These are the things which you have already done in our notes. This is called a Pinard maneuver. Yeah, Pinard maneuver is unlocking popliteal fossa to deliver extended legs. Yeah, when legs are extended, that is called a frank breech. Yeah, frank breech is most common breech. Yeah, guys and girls, Pinard maneuver is during delivery of extended legs. That means frank breech, unlocking popliteal fossa. Okay, guys and girls, after that there is one picture which is commonly asked in exam, where baby is rotated in order to release the extended arms. And you know that this maneuver, in this maneuver, you are rotating the baby in order to release the extended arm. This is called a low set maneuver. Low set maneuver, extended arms. Hold the baby, rotate the baby by 180 degree. The extended arm would come into the pelvis. One more rotation and the arm would get released. Yeah, low set maneuver. Guys, then this is the maneuver. Very important maneuver, where one hand is below the baby, one hand is above the baby, and you are doing the flexion over here. Yeah, this is malar eminence. So malar flexion, shoulder traction. This is called as MSV maneuver. Yeah, MSV, Morris Smelly wet maneuver. The original one was middle finger in the mouth. It was called a jaw flexion and shoulder traction. The modified one is malar flexion and shoulder traction. Yeah, this is Morris Smelly wet maneuver. Yeah, currently this is the most common maneuver used in order to deliver the baby. Yeah, guys, there is one more maneuver where you hold the legs of the baby and swing the baby on the abdomen of the mother. That's called as Burns-Marshall maneuver. But I presume this picture would be asked because this is the most commonly used maneuver in order to deliver the after coming head of the baby. Yeah, Morris Smelly wet maneuver. Understand that in Morris Smelly wet or in Burns-Marshall, the back of the baby is always anterior. Yeah, back of the baby is always anterior. If the back of the baby is posterior, then you are supposed to do this maneuver called Prague maneuver. Prague maneuver, where you are doing the same thing. You are holding the baby in this way, fingers on the shoulder and your dominant hand on the back of the baby, and you are removing the baby by swinging the baby in long arc with back of the baby posteriorly placed. So it is for dorso-posterior position. Yeah, dorso-posterior position, Prague maneuver is used. Yeah, so this maneuver is specially designed for dorso-posterior position. Now question is about breech, whether you would do vaginal delivery or cesarean section. What do you think is the right answer? Yeah, if she is primary with breech, you better do cesarean section. It's a relative indication. Yeah, if she has a previous LSCS with breech, you should do cesarean section. VBAC is not allowed. Vaginal birth after cesarean section is not allowed in malpresentations. Yeah, previous LSCS plus breech, you should do cesarean section. Obviously, they are in labor. Otherwise, same thing, primi plus breech. The answer would be ECV. Yeah, external cephalic version. Multi plus breech. The answer would be same, external cephalic version. But if they are in active labor, then primi plus breech should go for cesarean section. Multi plus breech should go for vaginal delivery. Yeah. Footling or kneeling should go for cesarean section. You should not attempt footling or kneeling cesarean. You should not attempt vaginal delivery because of the risk of cord prolapse. Yeah. So if there is breech presentation like footling breech, you should do cesarean section. Then maybe primi, multi, great grand multi, whatever. There is no terminology like great grand multi. Okay. So footling, kneeling, do cesarean section. Yeah. If there is a preterm plus breech, then you should better go for cesarean section, because preterm baby will not be able to tolerate breech delivery. The after coming head would undergo compression, decompression, and there would be injury to the baby like intraventricular hemorrhage. So preterm labor plus breech is equal to cesarean section. Am I clear? Yeah. There is one scoring system, ZATUCHNI. If this score is good, then do vaginal delivery. If the score is poor, you do cesarean section. Just remember the name, ZA score. Yeah. If it is good, do vaginal delivery. If it is poor, then you do cesarean section. Right? Guys, girls, stargazing breech should always go for cesarean section. Stargazing breech? What do you mean by stargazing breech? Baby is having extended head. Yeah. So baby is looking up with buttocks down. You should do cesarean section. Right? Guys, girls. Then if there is any other condition like CPD, I mean there is contracted pelvis, placenta previa, these will themselves become an indication of cesarean section. Yeah, guys, so this is what you should know about how to conduct delivery by cesarean or vaginal. If you are doing vaginal delivery, then remember it could be spontaneous breech delivery, then it could be assisted breech delivery, also called as partial breech extraction. Or it could be complete breech extraction. So total breech extraction. Spontaneous is wait and watch, do nothing, baby will come out on its own. Preferred in a condition where the baby is already dead. Yeah, fetal demise is there, you don't intervene, let the baby come out on its own. Partial breech extraction, you wait till the neck of the baby is delivered. I mean the neck is visible, and then you do active head delivery. Yeah, so partial breech extraction is active head delivery, and yes, Pinard and Losets are allowed. Here minimum intervention is done. You are not putting your hand inside vagina to deliver the baby out. That's assisted breech delivery, partial breech extraction, most commonly used. Yeah. And breech extraction would be done in a case of cord prolapse. Generally, cord prolapse management would be cesarean section, but if there is fully dilated cervix, then you have a possibility to deliver the baby out by breech extraction, if it is obviously breech. Yeah, am I clear? If there is cord prolapse, if there is fetal distress, then you do breech extraction. Put your hand inside and deliver the baby out. Yeah. Am I clear about this? Yeah. Nishit Anjum has written primi with recurrent epistaxis. Epistaxis. We are obstetricians. We never look the patient above umbilicus. Do you remember my statement? We always identify the patient looking at some weird things. Yeah, I told you ना, पेशेंट अगर रास्ते में मुझसे पूछे डॉक्टर साहब मुझे पहचाना, मुझे देखना पड़ेगा. Yeah, that's my answer. Okay, so I don't know what you're asking. Primary with recurrent epistaxis, Nishant, you have to ask me properly. Yeah, guys, I hope you are all with me. Let's talk about the next important topic, anemia in pregnancy. And yes, we have done in details about anemia in pregnancy. You know, most common anemia is iron deficiency anemia, and you know that we give oral iron therapy, we give injectable iron therapy, we give blood transfusion, but there's always a confusion when to give what. Yeah, we always have a confusion when to give what. Guys, remember this thing, that best treatment is oral iron therapy because it is safe, it is effective. IFA pills are given 2 pills per day, and you know one IFA pill contains 60 milligram elemental iron and 500 microgram folic acid. 2 IFA pills per day is best. But understand this thing, if patient is having non-compliance or patient is intolerant, or if there is any anemia means mild or moderate of more than 34 weeks, any anemia mild to moderate of more than 34 weeks, we give injectable iron therapy. We also give injectable iron therapy for severe anemia in early 3rd trimester. I repeat, oral for the initial treatment is the right treatment for all the anemic patients. But if patient is non-compliant or intolerant or any mild to moderate anemia of 34 week plus pregnancy, you should give injectable iron. Even severe anemia in early 3rd trimester, you should give injectable iron. Yeah, am I clear about this? Listen carefully. My dear friends, if patient is less than 11 gram, is having hemoglobin of less than 11 gram %, she is labeled as anemic. Agreed? 10 to 10.9 is mild. Yeah, 7 to 9.9 is considered moderate. Yeah, 7 to 9.9 is moderate. Less than 7 is severe. This is what you should know. Mild, moderate, severe. Okay, guys, are you all in the loop? हंस रहे हो अभी तक? Wake up, guys, wake up. Most important topic going on. पक्के आम तैयार हो चुका है. Let us deliver now, and yes, let us complete the things which are so important. Yeah, come back. Trans में से वापस आ जाओ. Okay. What I was talking about is anemia. Mild is 10 to 10.9, moderate is 7 to 9.9, severe is less than 7. So see in the question what they are asking. Yeah, and decide what is to be given. How do you decide, sir? Take this algorithm. If there is mild anemia or moderate anemia, yeah, mild or moderate anemia, what did I say? I said oral iron therapy is to be given. Oral iron therapy, mild, moderate anemia, oral iron therapy is to be given. Okay. What if the patient is non-compliant or intolerant? Then you are going to give injectable iron therapy. Yeah, mild, moderate anemia, oral iron therapy, non-compliant or intolerant, injectable iron therapy. What if mild, moderate anemia and she is more than 34 weeks? That means late 3rd trimester. Then you don't have time. You will always resort to injectable iron therapy. That's what I told you, na? Mild or moderate anemia with 34 week plus, you should give injectable iron therapy. Am I clear? So let's take a patient who has 8 gram % and she is 36 week pregnant. 8 gram % 36 week pregnant. अब भाई इसको ओरल देने की जरूरत नहीं है. ये ओरल लेगी शायद नहीं लेगी. She might take or she might not take, and she will come back to you at 39 weeks with 8 gram %, 40 weeks with 8 gram %, and you did this. Oh, why didn't I start injectable iron? Unnecessarily I will have to give blood transfusion, or unnecessarily there will be complications in labor. So remember, 34-week plus and any anemia, mild to moderate anemia, you should give injectable iron, parenteral iron, and iron sucrose, ferric carboxy maltose are the approved drugs which are given as injectable iron therapy. Iron sucrose, ferric carboxy maltose. Yeah. What about a patient who has severe anemia? As I told you, severe anemia is less than 7 gram%. Yeah. And I told you, severe anemia in early third trimester. Severe anemia in early third trimester, you are supposed to give injectable iron therapy. What about severe anemia in late third trimester? That means 34 weeks beyond. You will have to give blood transfusion. I'll give you a case. She is, let's say, 6 gram% case, 6 gram%, and she is 38-week pregnant. Your clear-cut answer is blood transfusion. 6 gram%, 38-week gestation, you have to give blood transfusion. If there is 6 gram% and let's say 30 weeks of gestation, don't waste time in giving oral iron therapy. You are supposed to give her injectable iron therapy. Yeah. Priya, you are right. Rate of rise of hemoglobin with injectable iron is same as with oral iron. Then why are we giving injectable in these 34-week plus patients? 34-week plus as in mild moderate anemia, 34-week plus. Because you are assuring compliance, because you are guaranteeing that iron is going inside her body. You are assuring that patient will not fool you. Yeah, you are giving iron to her. That is why. Okay, am I clear about this? Okay, yeah, I hope you are all on track, my dear friends. So this is about clinical scenario, clinical vignette, which will be asked in exam, and yes, you should know what should be your right answer approach. Yeah, 6 gram%, 38-week gestation, blood transfusion is the right answer. One exceptional thing, my dear friends, if patient has HB less than 5 gram% at any week of gestation, your only answer is blood transfusion and nothing else. Yeah, only answer is blood transfusion. So if patient is having hemoglobin 2, oh my god, 2, yes, we see patients with hemoglobin 2. We will not send her, oh okay, जा बहना बाद में आना. नहीं, not at all. वो बाद में नहीं आएगी अकेले, वो 4 कंधों पे आएगी. Yeah. So remember this thing, that any patient with hemoglobin less than 5, give her blood transfusion. As simple as that. Okay, got it? Very clear. This is what you should know about iron and anemia in pregnancy. Regarding hypertensive disorders in pregnancy, guys, this is must know topic. I'm not going into details of all these things, but what you should know are the things I'm telling you. Yeah, hypertensive disorders, gestational hypertension would be having 140/90, 2 readings, 4 hours apart, no proteinuria, no end organ damage, and this would be seen after 20 weeks of gestation. That patient becomes a case of gestational hypertension. You very well know this. Gestational hypertension, 140/90, 2 readings, 4 hours apart, no proteinuria, no end organ damage, more than 20 weeks of gestation. Yeah, one word of caution, guys, you need 2 readings 4 hours apart, but this rule, this law of 2 reading 4 hours apart is relaxed if patient's initial BP is 160/110. If patient is already having severe hypertensive condition, 160/110, don't wait for 2 readings 4 hours apart. Yeah, start the treatment then and there only, give her antihypertensive. Yeah, am I clear? Gestational hypertension. Then preeclampsia. Preeclampsia, ... but either there is proteinuria or end organ damage. Yeah, proteinuria or end organ damage would be a case of preeclampsia. Everything else would be same. Yeah, in proteinuria, you know that more than or equal to 300 milligram in 24 hours. Protein creatinine ratio more than or equal to 0.3. Yeah, urine albumin more than 1+. That means +2, +3, +4. any of these things would be significant proteinuria. Yeah, there might be a question like this: 140/90, 2 readings, proteinuria is present, it is 150 milligram per 24 hours. Label your diagnosis. Then please don't write it as preeclampsia. Then it would be a case of gestational hypertension, because significant proteinuria would be 300 milligram for labeling someone as preeclampsia. Otherwise, it would be a case of gestational hypertension. Yeah, Anubhav Singh, remember 4 hours. Yeah, some books have written 6 hours, but then 4 hours is written in Williams. Okay, am I clear about this? Nagmani has asked, postpartum anemia, ferric carboxymaltose preferred. Ferric carboxymaltose is preferred in antenatal also, in postnatal also. The only problem is with cost. If it is available, then that should be the preferred iron therapy. Yeah, ferric carboxymaltose can be given in one go. For iron sucrose, you will have to give again and again. So yes, I hope it is clear for you. Urine albumin in preeclampsia case, you remember more than 1 plus. That means +2, +3, +4. Okay. Earlier it was written as more than or equal to 1 plus. Now it is urine albumin more than 1 plus. Okay. Guys, eclampsia would mean the patient would have convulsion. Yeah. Yes, I'm telling you the latest thing, more than 1 plus. Yeah, more than 1 plus. Eclampsia, convulsion. Okay, got it? Guys, then if there is something called hypertension before 20 weeks of gestation, then chronic hypertension. So there will be 140/90, 2 readings 4 hours apart in less than 20 weeks of gestation. Chronic hypertensive patient. Yeah, less than 20 weeks, 140/90, you are dealing with chronic hypertension. Am I clear about this, guys and girls? Then if any chronic hypertensive patient develops new proteinuria or worsening proteinuria or end organ damage, you are dealing with chronic hypertension with superimposed preeclampsia or eclampsia. Yeah, if there is new proteinuria, worsening proteinuria, or there is end organ damage which was not there before. So I'll give you one case. Primi gravida, 18 weeks of gestation, BP 140/90, 2 times, urine albumin negative. Yeah, what is your diagnosis till this point? She is a case of chronic hypertension. Agreed. Now she comes at 30 weeks of gestation again. Her BP is 160, 110. Urine albumin has become 4 plus. She is also having headache. Actually, not many of these things are required. Even a single thing would be sufficient to label this patient as chronic hypertension with superimposed preeclampsia. Yeah. See, headache, blurring of vision would be marker of end organ damage in the CNS. Yeah, epigastric pain would be marker that liver capsule, Glisson's capsule is injured or gastric mucosa is injured. Yeah, or there is oliguria. Understand this thing, that a patient having oliguria, that means the kidneys are getting damaged. Try to understand this thing, that end organ damage are certain things which you should know, like SGOT, SGPT more than or equal to 2 times normal. Yeah, serum creatinine. See, oliguria per se is not sufficient to label someone as end organ damage. Serum creatinine more than 1.1 milligram percentage. That is important for labeling someone as end organ damage, and that is why superimposed preeclampsia. Yeah, then if there is premonitory symptom like headache, blurring, so I'll write cerebral or retinal symptoms. Yeah, so yes, headache, blurring would be cerebral retinal symptoms. If patient is developing pulmonary edema, then you are dealing with a patient who has developed end organ damage. So you will label this patient not as a clinical case of chronic hypertension. She has become a new case called preeclampsia superimposed on chronic hypertension. Am I clear about this? So platelet count is also one more thing which you should know. Platelet count less than 1 lakh is also an important marker of end organ damage. Okay. Oliguria per se is not sufficient to label someone as end organ damage. Create more than 1.1 milligram percentage is essential. Yeah. Am I clear about this? Yeah. So this is about a case of chronic hypertension with superimposed preeclampsia. Yeah. Guys, girls, remember, if there is gestational hypertension or preeclampsia which is non-severe, we can extend the pregnancy till 37 weeks. Non-severe gestational hypertension, preeclampsia, 37 weeks. If it is severe, then 34 weeks is the time when you have to terminate pregnancy. Yeah. So severe preeclampsia, the deadline is 34 weeks. Non-severe preeclampsia, 37 weeks. Eclampsia, termination is immediate. Immediate termination. Yeah. Is there need for magnesium sulfate in severe preeclampsia? Yes, sir. Magnesium sulfate is given as short-term therapy in severe preeclampsia and to see what is the response. Yeah. Got it? Very clear. Is magnesium sulfate necessary for eclampsia? Damn yes. Drug of choice for eclampsia is magnesium sulfate. Am I clear about this? Yeah. So guys and girls, you should know. What about chronic hypertension? Chronic hypertension can be terminated by 38 weeks. Yeah. 37 to 38 is the range, but 38 is the right answer. Chronic hypertension. Okay. Am I clear about this? Okay. After this, let us talk about diabetes. Now, guys and girls, for diabetes mellitus, you should remember about few things, and that is we follow DIPSI guidelines. So in this topic, I will not go into the whole details, but I will tell you what is important, and that will be DIPSI guideline for diagnosis. For the whole topic, you have to read the notes which you already written. Yeah, for DIPSI guideline, you remember it is 75 gram OGTT. Yeah, DIPSI guideline 75 gram oral glucose tolerance test, OGTT. You give 75 gram OGTT. Fasting is not necessary. Okay, fasting is not necessary. Patient is coming to you, she has had food, no problem. Madam, ले लो 75 ग्राम की पूड़ी. डॉक्टर 2 दिन से खाना नहीं खाया. मैडम आप तो पहले ले लो 75 ग्राम पूड़ी. Try to understand, fasting is not necessary. You have to check the blood sugar after 2 hours. And if the value is 140 milligram percentage or more, she is labeled as a case of gestational diabetes mellitus, GDM. Yeah. 140 milligram percentage is gestational diabetes mellitus. My dear friends, remember that there is something called overt diabetes mellitus, which you already know. As per American Diabetes Association, overt diabetes mellitus is a patient whose fasting value is more than or equal to 126 milligram percentage. Random blood sugar more than or equal to 200 milligram percentage. HbA1c more than or equal to 6.5 percentage. Either this or this or this is a case of overt diabetes mellitus. This is as per American Diabetes Association, ADA. Somebody is asking drug of choice for hypertensive disorder in pregnancy. Obviously, labetalol. We have done this many times. I'm not going to do those things again and again. Labetalol is the drug of choice for preeclampsia, gestational hypertension. If you are asked about drug of choice in chronic hypertension, then alpha methyl dopa is the right answer. Yeah. Okay. Got it. Chalo. After understanding how to diagnose, you should know one very important fact about gestational diabetes mellitus, and that is congenital anomaly risk is not increased in gestational diabetes mellitus. It is increased in overt diabetes mellitus cases, but not in GDM cases. So you might get a question like this: patient has gestational diabetes mellitus, she is counseled about the risk of all these things. What is not correct? You should know that congenital anomaly risk is not higher than general population. because gestational diabetes mellitus condition would happen more commonly in third trimester, less commonly in second trimester, but not in first trimester. If patient has diabetes right from first trimester or before that, you are dealing with pre-existing diabetes mellitus, pre-gestational diabetes mellitus. Yeah, I hope you got my point. If you get a question, drug of choice for GDM or overt diabetes mellitus, the answer is insulin. Yeah, but these are the days when clinical vignettes would be there. You remember, if there is any patient whose diagnosis you have made as overt DM, you are not supposed to give oral hypoglycemic agents. For them, the only answer is insulin. Okay? Oral hypoglycemic agents are allowed, but only in GDM case. Yeah, we give metformin therapy, but only in GDM case, not in overt diabetes mellitus. As simple as that. Yeah. Do we give diabetic diet therapy? Oh, diabetic diet therapy is given for all patients. May patient be having severe diabetes or non-severe diabetes, you are supposed to give diabetic diet therapy. Diet therapy is there for all, but metformin not for overt diabetes mellitus. Insulin can be given for both. Yeah, insulin is must in overt DM, but insulin is not necessarily compulsory in GDM. You can control it with metformin. Yeah, I hope you got my point. Guys, girls, macrosomia can be seen in both. Why not? GDM also, overt DM also. Macrosomia can be seen. Okay, got it? Very clear. Chalo, next is about RH neg preg. RH negative pregnancy. Patient is RH negative. Yeah. Do partners blood group. This is what is Indian scenario. We do partners blood group. In Western scenario, they don't do this. Yeah, they directly jump onto indirect Coombs test. Indirect Coombs test, ICT, is a prognostic marker. Yeah, in your Indian exams, you remember, if partner is negative, the answer would be do nothing else. But if partner's blood group is not mentioned, or if they have written partner's blood group positive, then you should do indirect Coombs test. If indirect Coombs test is negative, your role is to maintain it negative. Sir, how? By giving injection anti-D at right time, at right dosage. Yeah, what is the right dose, sir? Many times I am asked, sir, is the dose 300 for first trimester, second trimester, third trimester? Understand this thing, that right answer, even as per ACOG, is 50 microgram for first trimester and 300 microgram for beyond first trimester. Yeah, 50 for T1, 300 for T2, T3. Yeah, this is regarding exposure, like abortion, yeah, procedure, or delivery. These are considered as exposures. 50 microgram for first trimester, 300 microgram for T2, T3. Am I clear about this? Exposure, abortion, procedure, delivery. Now, my dear friends, try to understand this thing, that this is for exposure. Compulsory 300 microgram is given at 28 weeks. Yeah, 300 microgram at 28 week is compulsorily given to a patient who is RH negative. Yeah, in order to prevent the antenatal mixing of blood. Okay, got it? Very clear. And yes, when patient is given 300 microgram, this anti-D would take care of some amount of feto-maternal mixing which is happening in antenatal period. But that doesn't mean after delivery we are not going to give. Remember this thing, if she delivers at, let's say, 40 weeks, you are supposed to give 300 microgram again, provided baby's blood group is positive. When you are not supposed to give anti-D, anti-D is not given if partner is negative, partner blood group is negative, don't give anti-D. Anti-D is not given if baby's blood group is negative. So newborn baby's blood group is done and that blood group has come out as negative. Mother is negative, baby is negative. If the mixing has happened, it is negative blood with negative blood. Nothing is going to happen. We are not going to give anti-D injection at all if baby is Rh negative. If patient is ICT positive, then also we don't give anti-D injection. Why? Bhai, in simple language, can you prevent isoimmunization if patient is already isoimmunized? The answer is no. Her memory cells are already knowing how anti-D is produced because they are already exposed and anti-D production is already started in the body. Yes, that is why she is ICT positive. Now what is the aim of giving anti-D? Nothing will happen. Anti-D will not prevent isoimmunization. Our aim of giving anti-D is to prevent isoimmunization. This will not happen if ICT is already positive. Am I clear about this? Sir, can we give anti-D after 3 days of exposure? Yes. Anti-D can be given up to 28 days of exposure. Ideally given within 3 days of exposure. Yeah. Dave is asking in which abortion Rh anti-D is not required. Let me tell you that if all the options are like this, that anti-D injection is not needed after A. Ruptured ectopic, B. Amniocentesis, C. Threatened abortion, or D. Full-term delivery of a positive baby. Technically speaking, in all patients we are giving it. But then the best answer of all these things would be threatened abortion. In threatened abortion, the amount of mixing is as good as none. Yeah, that is why anti-D is not given as 4 options. As out of 4 options, this is the right answer. But remember this thing, if such a question is not asked, remember anti-D is given with any and every exposure in India. We give it. Better be safe than sorry. Yeah. If baby is Rh negative, we don't give, na? If partner is negative, the baby will be negative, na? Sir, partner negative, patient negative, we don't give anti-D and the baby is delivered positive. Please give. This baby is not the baby of this partner. I hope you got my point. So take home message. After delivery, you always check the blood group of the baby. As simple as that. If baby's blood group is negative, don't give. Baby's blood group is positive, give. Within 72 hours of exposure. Okay. I hope you got my point, my dear friends. This is what you should know in our topic called Rh neg preg. Then comes question on antenatal fetal assessment techniques. Now here I would present to you some pictures only, not the whole description. If this is a picture of a patient who is gravida 2, para 1, living 1, gestational diabetes mellitus, 33 weeks of gestation. Yeah, this is the clinical vignette and this picture is given. Gravida 2, para 1, living 1, 33 weeks of gestation, gestational diabetes mellitus, on insulin therapy and cephalic presentation. Firstly, what is this picture of? This picture is of non-stress test. Yeah, you are seeing accelerations. Yeah, there should be 2 or more accelerations. 2 or more accelerations in 20 to 40 minutes. Okay, 2 or more accelerations in 20. People are still in loop. Come out, my dear friends. You are still laughing. होता है कभी कभी negative patient, negative partner and the baby positive. Then you are in trouble. Yeah, it has happened. In clinical practice, it always happens. You will get some patients like this. Yeah. And then you have to talk to the patient, not to the partner. कि भाई क्या करना है? You want to tell or you don't want to tell? Yeah. Doctor, tell. Doctor, it is better you tell. Yeah. It was my brother-in-law. Nah, whatever. Sorry. Ignore weird things. Concentrate on good things. This is gravida 2, para 1, living 1, GDM patient, 33 weeks of gestation, insulin therapy going on, cephalic presentation. This is NST. Can I label this as healthy baby? Yes, the baby is healthy. This is NST. The reason is there are 2 or more accelerations in 20 to 40 minutes. Okay, you are seeing so many accelerations. in 20 to 40 minutes. Yeah, this is one way of knowing things, whether the baby is healthy or not. Yeah, if I combine NST plus AFI, what have I made it? I have made it as modified biophysical profile. Modified biophysical profile. Yeah, guys, if both the components are normal, NST is normal, AFI is more than 5 centimeter, continue pregnancy. If any component is abnormal, do complete biophysical profile. So same patient, if they have written that NST is non-reactive, yeah, AFI is less than 5, any component is abnormal, they have written it like this, yeah, then you are supposed to do biophysical profile. I know you people know that it is called a Manning's score. Manning's score, biophysical profile. In that scenario, you are doing USG for 30 minutes. You already done NST for 20 to 40 minutes. Yeah, the components in USG which you see would be fetal breathing, gross body movements, NST, obviously NST is a part over here, yeah, then fetal tone and amniotic fluid levels. Yeah, this is biophysical profile. Each component is given 2 marks. Breathing for 30 seconds, gross body movements 3 episodes, NST reactive, fetal tone flexion, and amniotic fluid single deepest pocket more than or equal to 2 centimeter. Congratulations, if all 5 components are normal, then the total score is 10. Continue pregnancy. Yeah, I will oversimplify this for you. 8 or 10, continue. 6, reassess after 4 hours. 0, 2, 4, terminate. As simple as that. This much you remember, that's it. 0 to 4, terminate. 6, reassess. 8 or 10, 8 on 10 or 10 on 10, continue. Yeah, this is biophysical profile, also called as Manning's score. Modified biophysical profile is NST plus AFI, and NST 2 accelerations or more in 20 to 40 minutes. Yeah, this is what is about fetal monitoring in antenatal period. Then fetal monitoring in labor, you will get pictures like this. Patient is in labor, let's say same patient. And you are finding this picture. First and foremost, this is cardiotocogram. Cardiotocogram, where uterine contractions are present. NST had flat line over there. Cardiotocogram, there are uterine contractions, and with the contractions, there are decelerations happening. Decrease in heart rate by 15 beats for 15 seconds. Yeah? Guys, girls? So yes, uterine contractions are there, and at the same time there is deceleration. Thank God the decelerations are happening at the same time and they are disappearing after the contraction. So this is early deceleration. It is due to head compression. Nothing to worry about. Continue labor. Yeah, this is physiological. This has to happen. This will happen because head gets compressed in labor. Yeah, are there accelerations? Yes sir, acceleration is also there, seen, but in labor we don't give much importance to acceleration. Even if accelerations are not there, we are happy if there are no late or variable decelerations. Yeah, guys, girls, so yes, this is early deceleration. Head compression is the reason. Then you might see such picture in exam. Yeah, this is not physiological, this is pathological. The contraction has happened, and exactly after the contraction there is a depth of the deceleration. Yeah, exactly after the contraction, there is a depth of deceleration. This is late deceleration. This is seen in uteroplacental insufficiency. Late deceleration, uteroplacental insufficiency, example, preeclampsia, IUGR, maternal hypotension. Yeah, hypertension also causes this, hypotension also causes this. Whatever reduces the blood supply to the baby, whichever condition reduces the blood supply to the baby would cause late deceleration due to uteroplacental insufficiency. Yeah, you try to improve the blood flow to the placenta, IV fluids. So, ringer lactate solution is given, left lateral position is given, O2 inhalation is given, and try to see that you improve the blood flow to the placenta. Yeah, guys and girls, this is the initial management. If the management fails, then you know that you have to immediately terminate the pregnancy either by instrumental delivery or by cesarean section. Now, have you realized that in early as well as in late deceleration, the graph went down gradually and came up gradually? The starting point and the lowermost point were more than or equal to 30 seconds away from each other. Starting point, lowermost point, more than or equal to 30 seconds away. So these are gradual decelerations. But if you see a sudden deceleration, you know you are dealing with something really bad. Sudden deceleration would be variable deceleration. The starting and the lowermost point would be less than 30 seconds away from each other. And this is due to cord compression. Yeah, cord compression. So cord prolapse must have happened, oligohydramnios causing cord compression, or cord around neck, nuchal cord, cord around arm, or true knot may do this. Anything which causes cord compression will cause variable deceleration. Sometimes when we do ARM, sudden gush of fluid can also sometimes cause cord compression, but that would be transient one. Yeah, when there is a cord prolapse, it would be permanent one, of course. Cord aa gaya baad mein, cord aa gaya haath mein, that's a very dangerous thing. Yeah, so always check for cord prolapse, always do PV examination, always rule out cord prolapse. हमारे तो हॉस्पिटल में whenever there is any case of distress, labor ward में distress हुआ, compulsory PV examination करना ही है. Residents are taught this thing that PV examination is must. Yeah, whenever there is distress, and you know in your labor ward, dhak dhuk, sometimes dhak dhuk, hey PV kar, that is always there in our labor ward. Yeah, we want to know whether there is a cord prolapse or not. If PV kar, there is a cord prolapse, that person is told to keep the hand inside. Yeah, you have to manually push the head up into the pelvis so that the cord compression is avoided. Yeah, and then prepare the patient for cesarean section. Yeah, in cord prolapse, you don't allow the head to come down. Manual pushing of head above is to be done. Cystodistension should be done. Head low position should be given. Yeah, guys, because you don't want the head to compress the cord, and you have to prepare the patient for cesarean section. Okay, am I clear about this? This is variable deceleration. What if there is no cord prolapse? There is no cord prolapse. It could be due to less amniotic fluid. There is a role of amnio infusion. If there is no cord prolapse, then you do amnio infusion, where you are putting normal saline, warm normal saline into the amniotic sac with the help of catheter, and that is called amnio infusion, and this will be the treatment for variable deceleration. Okay, guys, girls, remember this thing, that always cord compression has to be prevented. Yeah, cord compression. If there is a cord prolapse, see to it that sometimes you might not see the cord. Cord might be in the vagina. If you are seeing the cord, you cover the cord with wet gauze and deposit in vagina. Yeah, try to understand this thing that you have to do PV examination, maintain PV examination, and pushing of head up is most important thing. And in that process, you are obviously asking for help, and then head low position is given. Yeah. So remember this thing, cover the cord with wet gauze, repose it in vagina, maintain the position, manual pushing of head, and Trendelenburg position, head low position is to be given. Yeah. I hope you got my point. This is variable deceleration. Okay. Let us talk about antepartum hemorrhage now. Guys, if you get a patient with painless, causeless, frequent, fresh, heavy vaginal bleeding in second half of pregnancy, what did I say? Painless, causeless, frequent, fresh, heavy vaginal bleeding. You will typically get this patient, doctor, when I woke up in the morning, I saw myself in pool of blood. That means she had heavy bleeding. She woke up in the morning, she saw herself in pool of blood. That means it was painless. Yeah, she did not even perceive that she had bleeding. Yeah, causeless. There is no trauma, there is no hypertension, there is no cause. Frequent, this happens again and again. It will be fresh blood. Yeah, it will not be collected, dark colored as in abrupt show. Yeah, it will be heavy blood bleeding. This is placenta previa bleeding. Your diagnosis would be placenta previa bleeding. Don't ask me about first trimester bleeding, because that is different story altogether. That is hemorrhage in early pregnancy. This is painless, causeless, frequent, fresh, heavy vaginal bleeding. In clinical vignettes, if you get such a question where patient is gravida 2 para 1, living 1, 34 weeks of gestation, has come to you with painless vaginal bleeding, your system should go and work towards diagnosis called placenta previa. Yeah, painless, causeless, frequent, fresh, heavy vaginal bleeding. Yeah, abrupt show placenta would have pain, uterine tenderness. Yeah, bleeding would be less than placenta previa. So mild to moderate vaginal bleeding, but shock more than bleeding. Yeah, mild to moderate vaginal bleeding, but shock more than bleeding. You will typically see these patients coming to you with pain in abdomen. Doctor, bahut dukh raha hai, doctor. And when you touch it, oh my God, when you touch it, she will shout with pain. And there is a continuous trickling of altered colored blood coming out. 34 weeks of gestation, altered blood coming out, and she has tenderness in uterus. So you are dealing with abrupt show placenta. Yeah, shock more than bleeding. You might see uterus more than period of gestation, because blood is getting accumulated in concealed abrupt show. Yeah, uterus would be equal to period of gestation in placenta previa and also in revealed abrupt show. Yeah, revealed abrupt show would have uterus equal to period of gestation, and in concealed abrupt show or in mixed abrupt show, uterus would be more than period of gestation. That is what is there in abrupt show placenta. Yeah, never ever do PV examination in placenta previa. How do you know she is placenta previa case? Remember this line: painless bleeding, never do PV. Painful bleeding, always do PV. Yeah, painless bleeding is a marker of placenta previa. You don't do PV examination. You better do transvaginal sonography, which is investigation of choice. Painful bleeding, you always do PV. Yeah. See, in our hospitals, sonography is so commonly available. It's there in our labor ward as well nowadays. So when a patient has come to your clinic and she is not registered anywhere, you always put a sonography probe on the abdomen and see where the placenta is. Na? If patient is already registered with you, she is following up with you, you know that papers are available that placenta is fundal posterior, it cannot migrate and become placenta previa. Na? In that case, you don't go for PV sonography again. You know that placenta is upper placenta, it is not placenta previa. You don't go for sonography again. Yeah, abrupt show is a clinical diagnosis. PV examination is done, ARM is done. artificial rupture of membrane, because you are going to save life with ARM. By doing ARM, you are converting concealed abruptio to revealed abruptio, and that is how we prevent the patient from dying, the baby from dying. We do artificial rupture of membrane. Yeah, and then terminate pregnancy. Obviously, you are doing ARM, you are going to terminate pregnancy. For your level, remember this thing: abruptio requires termination. There are very rare cases of chronic abruptio, mild abruptio, which are maintained and observed in hospitals. And if the bleeding is not continuous and if the vitals remain stable, then there is a chance of continuing. But for you people, remember this thing: abruptio is equal to termination. Okay. Can I say the same thing for placenta previa? Placenta previa is equal to termination? No. There's something called expectant management. And famously asked question, McPhee-Johnson regime. McPhee-Johnson regime for placenta previa is expectant management. You wait and watch till 37 weeks, provided mother and baby are normal. That means there is no fetal distress, vitals are stable, no active bleeding. Yeah, and you are at higher center. You can't do it at primary health center. Yeah, so if I make one case, Gravida 2 para 1 living 1, Gravida 2 para 1 living 1, 32 weeks gestation, complete placenta previa, 32 weeks complete placenta previa, cephalic presentation, history of bleeding last night, now no bleeding, fetus has no distress and pulse BP normal. What are you supposed to do? Your clear-cut answer for this case is McPhee-Johnson regime. You are going to do expectant management. You keep her admitted, obviously. Check her hemoglobin, obviously. But keep her admitted and do expectant management. If need be, you give blood transfusion. Because she has active bleeding, she has had active bleeding, you should give blood transfusion if need be. Yeah, if let's say her hemoglobin is indicative of blood transfusion, you know now when you are supposed to give blood transfusion. Yeah, so you should give blood transfusion if need be. Let's say if there is a patient who has fetal distress, you can't do McPhee-Johnson regime. If there is active bleeding, you can't do McPhee-Johnson regime. If there is no active bleeding, no fetal distress, you can do McPhee-Johnson expectant management. Give anti-D injection if she is Rh negative. If ICT is negative, Rh negative, partner positive, you should give anti-D injection. Yeah, I hope you got my point. If there are uterine contractions, then tocolytics to reduce the contractions can be given. You want to continue and stretch till 37 weeks. That's McPhee-Johnson regime. Am I clear about this, guys and girls? So for a patient who has placenta previa, the figure is 37 weeks for expectant management, and if she has active bleeding or she has fetal distress, then there is no figure. You have to terminate immediately. Okay, am I clear about this? All right. After this is about a question about postpartum hemorrhage. Remember, prevention and treatment of postpartum hemorrhage is by injection oxytocin. Yeah, we give injection oxytocin. Prevention dose injection oxytocin, 10 international unit IM. WHO wise, there is something called active management of third stage of labor. In India nowadays, we are doing something weird, and that is called a deferred cord clamping and giving oxytocin only when needed. Indian protocol. In WHO's protocol, oxytocin is compulsory for prevention of PPH. Active management of third stage of labor. Delayed cord clamping. Yeah. Here we do deferred cord clamping. We don't clamp the cord. This is the Indian protocol, okay? Deliver the baby, let the placenta come out, and then you clamp the cord. That is deferred cord clamping. That is what is the latest in thing. Yeah. In WHO's protocol, you know, active management of third stage of labor, we do delayed cord clamping. Wait for 1 to 3 minutes after the cord, after the placenta, after the baby is delivered out, and then clamp the cord. 1 to 3 minutes is the time given by WHO. Okay, got it? Very clear. Ricky is asking, can we give tranexamic acid? Yeah, of course. Any bleeding? Earlier tranexamic acid, the effects were considered equivocal, but now we say tranexamic acid, yes. Okay. Even you know, WHO recommends tranexamic acid for prevention of PPH and treatment of PPH. Yeah, the rule is PPH should not be more than 3 hours old for tranexamic acid to act. Yeah. Mona is asking, yes, ये क्यों किया? अच्छा, ये क्यों किया? As in deferred cord clamping. It's called Gujarat model. Yeah, there was a study done in Gujarat and also in West Bengal. Wow, two definitely opposite end of the spectrum in all the means. Yeah, but then yes, that study was approved by Indian government, and then Indian government has issued guidelines to all the colleges to do deferred cord clamping. This is what is written. Yeah. Sanam is asking, in HIV, is it early cord clamping or delayed cord clamping? Remember, I will tell you NACO guidelines where they have written weird statement, and that is do early cord clamping after cord pulsations have stopped. What do you mean by that? After cord pulsations have stopped means you're waiting for cord pulsations to stop. You're already waiting for more than 1 to 3 minutes. I would pick up for HIV as delayed cord clamping, but the words written in NACO guidelines are early cord clamping after cord pulsations have stopped. So I would recommend you to write delayed cord clamping in HIV. Okay, got it? Very clear? Yeah. So prevention and treatment of PPH, you remember drug of choice oxytocin, 10 international unit IM. For active management of third stage of labor, tranexamic acid is also used. Yeah. Treatment of PPH, oxytocin, 20 international unit IV, 20 here IM or IV is allowed, 10 international unit IM IV. Here the dose is 20 international unit IV in Ringer lactate diluted solution. Yeah, got it? Very clear? Alright, so oxytocin is the drug of choice in prevention and treatment of PPH. I'm not going into the details of treatment of PPH, but remember this thing, oxytocin is the drug of choice. This is what you are going to do. In clinical vignettes, if you get a question, patient has delivered a baby and suddenly she develops severe bleeding and she has atonic uterus or uterine tone is flabby, you are supposed to do bimanual uterine compression. Remember, bimanual uterine massage is for treatment of PPH, not for prevention of PPH. Yeah, it's for treatment of PPH, not for prevention of PPH. Bimanual is too invasive for something called prevention, but bimanual is compulsory for treatment of PPH. Am I clear about this? Yeah. Early cord clamping is for RH negative pregnancy. Somebody asked, no? Yeah, RH neg preg, early cord clamping. Birth asphyxia, early cord clamping. But HIV, I would pick up delayed cord clamping because of this statement. Okay, chalo. Next thing about abortions. Now, I am not going into the latest thing which was passed in Rajya Sabha yesterday, that the new MTP bill is passed in Rajya Sabha. It is just waiting for the president's signature, and then MTP will be allowed till 24 weeks. Yeah, 20 to 24 is the latest update, but it is still passed in Rajya Sabha yesterday. It's not even passed by president. So if that happens, you will get to know for sure. Right now, abortion, remember, termination before 20 weeks. Yeah, if patient is like this, patient is gravida 2, para 1, living 1 with 8-week gestation, 8-week gestation with bleeding PV. Uterus corresponds to 8 weeks. Os is closed. Yeah. USG shows alive fetus. Yeah. USG shows alive fetus. Or uterus is corresponding to period of gestation. Os is closed. Alive fetus. This is the diagnosis called threatened abortion. Diagnosis would be threatened abortion. If os is open or membranes have ruptured, not obviously in 8 weeks. So if I say 18-week os open, membranes absent, then it is inevitable abortion. Yeah, 18-week os open or 8-week os open. If I am writing membranes present, obviously it is in second trimester. Membranes are ruptured, then also inevitable abortion. Yeah, guys. So threatened abortion, inevitable abortion. Then if let's say history of passage of products of conception and os is open, then it is incomplete abortion. History of passage of products of conception, os is open, that's incomplete abortion. History of passage of products of conception, os is closed, then it is complete abortion. Complete has to be confirmed by USG. USG should show empty uterus. Then only you will label it as complete abortion. She has history of passage of POC, os is closed, USG showing empty uterus, then it is complete abortion. Yeah, guys. Then there is a patient who has dead fetus inside uterus before 20 weeks. It is called missed abortion. Dead fetus. So there is gravida 2, para 1, living 1, 16 weeks of gestation, and uterus is just 10 weeks. So there is a discrepancy. Whenever this discrepancy, we send for sonography. Sonography is showing dead fetus. This is a clear-cut case of missed abortion, also called as early fetal demise. Yeah, guys, this is missed abortion. Out of all these abortions which you have heard, let's add on septic focus to it. It becomes septic abortion. In all the abortions which you heard, let's add septic focus, it becomes septic abortion. Yeah, guys. So threatened abortion, inevitable abortion, incomplete abortion, complete abortion, missed abortion, and septic abortion are the abortions which you should know. Out of all these abortions, threatened abortion can be conserved. So bed rest, progesterone therapy would be given to threatened abortion. Yeah, complete abortion, reassurance. Obviously charge money, your fees are important. Yeah, but then you are just doing reassurance and nothing else. Okay, for inevitable, incomplete or missed abortion, you are expediting the process of evacuation of uterus. So suction and evacuation is a surgical treatment. For inevitable, incomplete, missed abortion, suction evacuation is the surgical treatment. You can also opt for medical treatment by prostaglandin tablet in vagina, but then the bleeding will be haphazard and for long time. The best treatment would be suction and evacuation, that would be surgical management. For septic, you have to cover septic focus and then do the same treatment as above. Yeah, septic focus has to be treated by antibiotics, and if need be, then anti-gas gangrene serum if there is any foreign body. Yeah, so that is all about abortion thing, guys and girls. Little bit about molar pregnancy. Molar pregnancy, my dear friends, this picture would be commonly asked in exam. This is snowstorm appearance. Yeah, so uterus will be more than period of gestation, no fetus inside uterus. Yeah, and there are grape like vesicles. Past. There would be most common symptom called as bleeding in first trimester or second trimester, early pregnancy. This is complete mole, and the treatment of choice for complete mole, suction and evacuation. Yeah, so treatment of choice, suction and evacuation, followed by HCG monitoring weekly. HCG monitoring has to be done weekly till it is undetectable. Yeah, till HCG is undetectable. Then monthly for 6 months, and request the patient, please don't become pregnant again for these 6 months. Why, sir? If you become pregnant again within 6 months, then your HCG will rise again. And I will get confused whether this HCG is from new pregnancy or from the cancer which has arisen from molar pregnancy. Yeah, so remember this thing. She has to be advised contraceptives for 6 months, low dose ocipils for 6 months. I'm not going into classification of what are the characters of complete mole and partial mole, but remember, even for partial mole, the treatment remains the same. Suction and evacuation, HCG monitoring weekly till undetectable, monthly for 6 months, low dose ocipils for 6 months. Don't put copper T. Copper T in the soft uteri would cause perforation, and copper T can cause bleeding. Copper T is contraindicated. Low dose ocipils would be the best thing. Okay, am I clear about this, guys and girls? So this is what you should know. Few pictures before I call it a day. In clinical examination, this is the picture which is commonly asked. This is of Hagar sign. It is seen between 6 to 10 weeks. Pregnancy in upper part and softening of isthmus. And empty lower part. Softening of isthmus and empty lower part. That would be a case, that would be a sign called Hagar sign. Similarly, there is a sign called Palmer sign. Yeah, Palmer sign is regular, rhythmic, uterine contractions on bimanual examination. What is happening is bimanual examination. If you are feeling regular rhythmic uterine contractions, that's Palmer's sign. Yeah. Then there is something called Osiander sign. There is something called Piscasek sign. Yeah. There is something called Goodell sign. Goodell is softening of cervix. Osiander, lateral fornicial pulsations, and Piscasek is asymmetrical uterus due to lateral implantation. All things are given in your notes. This is just a revision thing, that asymmetrical uterus due to lateral implantation. Okay, guys, girls, this picture, I expect this picture to come in exam again. This is asked many times. This is Leopold grip. Tell me the grip number. Leopold grip. This is grip number 3, also called as Paulik grip. Most commonly, you feel the head of the baby over here, and it would be hard ballotable mass. If this picture is given, it is for diagnosis of presentation. Leopold grip is hard globular mass, and one hand is used, and yes, you have to face the face of the patient. This is for presentation. This is Paulik grip. Okay, thank you very much, guys. This is all about obstetrics. these are important topics, and yes, I thought that in such a short duration, at least you should know these things in must know topics. Okay, now we will be starting with radiology, and most awaited, in fact, would be sir's radiology must know topics, and you will get lots and lots of images of radiology. Okay, I hope you people enjoyed it. I hope you people loved it. I hope you people will revise it well, and I hope you people become resident doctors soon. Okay, thank you so much. Bye bye, take care. That's all from me.